welcome Peter Dubal from South Africa, who's been quite instrumental in getting everyone advanced in laser technology. I don't know if it wasn't for him, I don't know if we would have lasers in South Africa, so thank you. And he's going to introduce you to Beata, who's sitting in London. Thank you, Peter.
Hey. Good evening. Good evening. Beata, your reputation exceeds you. I know some of our good friends, mutual friends, Dr. Mark Cronshaw and Dr. Renee Al-Falaki, also in London. They've been to South Africa many times over the years. They've really been instrumental actually in setting a foundation in South Africa and also in Denmark, because they've also both been to Denmark and had training sessions there. So please prepare to pack your suitcase also to go to Denmark, hopefully early in 2022. So just before I introduce you further, I just want to also welcome Dr. Avi Thomas from Vredendal, South Africa. Dr. Avi Thomas is also one of our heroes in South African dentistry. He started off with a mastership at Aachen University, then an MSc, and he's also now got a training with a WCL as a trainer in a mastership level with the World Clinical Laser Institute. Then we've also got Dr. Alex Hartman, one of the first doctors in Denmark, him and his wife, Dr. Anne Hansen, to introduce the water-laser technology and EPIC 940 nanometer diode laser into their practice. They also flew all the way to South Africa, to Cape Town, like they didn't need an excuse to come and do the mastership. And next year, we're actually hosting the first ever Aachen University laser mastership course in their town in Denmark. And it's really because of them that we're having it in their town. And we just want to welcome Alex. Thank you for putting time aside. I think we're on the same time zone in Denmark, Alex.
Yes. Yeah. Yeah.
We are. So
yes.
Anybody from the Denmark area that are listening, there will, as far as I know, will be a recording later. So if there's any questions also from South Africa, hopefully Dr. Alex from a Denmark perspective and Dr. Avi could answer with regards to the scope of practice where oral hygienists are using laser in the dental environment, because that obviously is a bit of a question that could come up. And I know that the laws are slightly different, possibly to South Africa and the UK and Denmark. So we might just have to touch on that. And then Beata, I'm trying to pronounce your name best I can. So welcome. We really appreciate you taking time out to speak to us across these platforms. We've also got even Beatrice from BIOLASE. She's sitting in Madrid online as well. So it's a real international panel here. And I just want to also congratulate you, Beata. I've heard that you're a finalist in the UK Oral Health Awards as well. So that's really phenomenal. And also just, I think a week ago, you also now, as far as I know, the first and only oral hygienist that is a trainer with the World Clinical Laser Institute as well, that can give lectures on behalf of the World Clinical Laser. So that's also a huge accomplishment. And I think you've also setting such a wonderful standard for oral hygienists to step up to, because as far as I know, and you'll get into it, you're using the lasers, the 940 nanometer diode laser, as well as the erbium chromium, aka the water laser, to treat your patients. So I think it's wonderful to see someone like yourself, step up to the mark and not just say, oh, well, I'm not a dentist, so therefore, maybe I can't push the boundaries. And you certainly are. And I think it's an inspiration to other oral hygienists, not only in South Africa or Denmark, but around the world. And even more so to dentists to say, well, if you can do it, then surely I can do it, So we really look forward to you speaking to us tonight and sharing your knowledge and your experience. And without further ado, I hand over to you. Thank you.
Brilliant. Thank you. Thank you so much. I feel really privileged to be here tonight. And thank you for such a lovely invitation. And I hope you enjoyed tonight's webinar, and thank you everyone for joining. Tonight, we'll be talking a lot about application of lasers from hygienist and therapist point of view, but with all respect of any dentist joining us tonight, and I'm sure there are a few, or any specialist, I'm sure you'll find something interesting. And at the end of the presentation, again, I'm welcoming any questions you may have. So my name is Beata Knysak. I'm a dental hygienist and therapist, and I qualify from King's College Hospital in London with a distinction for my research project on laser therapy and non-surgical periodontal treatment. And also I received an award for academic excellence. I'm a laser safety officer, and just like Peter said, a week ago, I've been awarded a fellowship accreditation from Ward Clinical Laser Institute. I'm really passionate about application of non-invasive dental lasers, mainly diode laser and erbium chromium YSGG laser within the scope of dental hygienists and therapists. And tonight I would like to talk to you a little bit about the benefits of diode as well as the erbium chromium YSGG laser and its application. I will mention about some of the clinical procedures and treatment protocols for non-surgical periodontal therapy, treatment of dentine hypersensitivity, after ulcers, herpes simplex virus 1, desensitization, as well as the tooth whitening. I will share with you some of my clinical cases, and at the end, we'll briefly discuss the implication of laser use, not only for dental hygienists and therapists, but for all dental care professionals. I just want to share the disclaimer that the content, recommendation, and the views expressed during these presentations are mine, and also the opinions and protocols used during this presentation are not FDA approved. So laser therapy has been used in conjunction with general dental procedures for over 3 decades. We know that in recent years, patient awareness about laser has increased. Therefore, we have a duty to understand how this technology works and also how we can implement this technology within our scope of practice, and to a degree to inform patient about their effectiveness. I strongly believe that laser can greatly expand a field of dental hygiene and therapy in order to perform even more efficient and minimally invasive treatment. So some of the application of diode lasers within dental industry are listed on this slide. First, the treatments that dental hygienists and therapists can perform within their scope of practice, especially here in the UK. That will be laser bacterial reduction without tip initiation, photobiomodulation, or also known as low-level laser therapy, treatment of dentine hypersensitivity, treatment of after ulcers, hepatic lesions, and teeth whitening. Some of the treatment outside of dental hygienists and therapist scope of practice would mainly require use of initiated tip, which is also known as the hot tip, which will mainly involve tissue incisions, some biopsies, vestibuloplasty, soft tissue, crown lengthening, exposure of unerupted teeth, dental implant, frenectomy, as well as the incision and drainage of the abscesses, and many more. And some of the application of erbium chromium YSGG laser by dental hygienists and therapists would include periodontal pocket decontamination. So that's, we know that the laser, YSGG laser has a shallow penetration of the soft tissue. It is roughly about 2.5 microns. However, we also know that microorganisms will penetrate within dentinal tubules, which will cause incomplete plaque bacterial removal, which subsequently can lead to treatment failure. Hence, we need something to penetrate within dentinal tubules in order to decontaminate them. Also, selective subgingival calculus removal. As we know, the erbium lasers have greater affinity to water and hydroxyapatite. And we also know that mineral composition of dental calculus, amongst others, is hydroxyapatite, and about 20% is an organic substance. Treatment of dentine hypersensitivity, and during cavity preparation, class 1, 2, 3, 4, and 5, through the hydrophotonic ablation, where the laser energy excites the water within the cells, causing the absorption of the laser energy and resulting in micro explosions. So why do we use diode lasers? Diode lasers has multiple benefits, and especially in treatment of periodontal disease, which I mainly specialize. It would be a significant reduction of bacterial load and slowing down their recolonization. I'm mainly talking about periopathogenic microorganisms such as Porphyromonas gingivalis, Thanerella forsythia, Prevotella insimedia, Fusobacterium nucleatum, and Aggregatibacter actinomycin comitans. We know that these pathogens are mainly darkly colored pathogens, and we know that diode has great affinity to pigment, to hemoglobin, to a lesser extent to water. Diode laser also reduce biochemical mediators such as cytokines, prostaglandins, and MMPs, and also reduce the risk of bacteremia, which is quite important when it comes to treatment of immunocompromised patients. They no longer need antibiotic cover. So that will be as we know, bacterium is a risk of cross-contamination of bacteria from the mouth into circulation. Also, light laser eradicates virulence factors of gram-negative bacteria, such as lipopolysaccharides and proteases, and also allows contraction of collagen fibers in the blood vessels, leading to vasoconstriction, and facilitate collagen production. Angiogenesis, the release of the growth factor, which ultimately initiate wound healing and improve clinical parameters, just bleeding and probing, pocket depth, and tooth mobility. It has stimulatory effect on mitochondria, so will increase production of ATP in mitochondria, leading to decreased time of cell replication. So hence we have a quicker, faster healing. Also, diode laser has biostimulatory effect on periodontal ligament stem cells, so that's osteoblast as well as fibroblast, leading to improvement in vertical intrabony defects. And because it can project, the laser light will project through bends and curves, it allows us to reach difficult to reach the intraoral sites, such as concavities, vertical intrabony defects, and furcations. And in treatment of dentine hypersensitivity, it will allow the increased temperature of the tooth surface, causing either complete or partial closure of dentinal tubules. Hence, we see the almost immediate improvement in dentine hypersensitivity. Also reduce the need for local and systemic antibiotic treatment, and consequently the risk of antibiotic-resistant bacteria strains. We know they are actually on the increase nowadays, and there's also no complications. It also greatly eliminates the need for any costly and painful surgical procedures, as well as the post-operative complications. And last but not least, it's safe to use on pregnant women, children, and as I mentioned before, medically compromised patients, since there is no antibiotic cover that's required. So some of the benefits of erbium chromium YSGG laser, so there will be a degree of surface decontamination, so in hard as well as in soft tissue application. It reduces the need for local anesthetic. I would say perhaps more likely with some restorative procedures rather than a soft tissue treatment. It allows access to difficult to reach intraoral sites. It allows us conservative tooth preparation, so not like with amalgam, we would have to actually remove a healthy tooth structure in order to retain the amalgam within a tooth. And when it comes to, for example, class 2 cavity preparation, we can actually access the mesial distal aspect without removing marginal ridge, which is really important. And in cavity preparation, there's no vibration. We can preserve a healthy tooth structure, and there's no microfracture that cause from, as we would happen with conventional burst. There is an etch surface without a smear layer, which is equally important in a cavity preparation as well as in a periodontal treatment, because it will allow a better fibroblast adhesion. And it provides a stronger bond, less post-operative sensitivity, and delamination of composite materials. There is little or no change in pulpal temperature. I think there is a maximum of 2 degree temperature increase in comparison to just conventional treatment, whereas between 2 to 4 degree change. And there's also safeties in pregnant women, children, as well as in nervous patients. and there are some great patient and clinician related outcomes, which I'm going to discuss a little bit later. So with regards to periodontal disease, we know that almost half of the adults aged 30 years and older suffer from gum disease, and unfortunately the risk increases with age. We know that periodontal disease is a major public health concern due to its high prevalence, because it can lead to tooth loss, but it can also negatively affect the chewing function, aesthetics, and is also, as we all know, a source of social inequality and can significantly impair quality of life. We know the initial treatment of periodontal disease mainly focus on addressing patient behavior, managing plaque, microbial plaque factor, also conventional non-surgical periodontal therapy, and the last consists of mechanical and manual removal of supra and subgingival plaque biofilm. And if it's not successful, we know that we would usually refer to specialists for more invasive surgical treatment. But we also know that conventional non-surgical periodontal therapy has many limitations, which would be, what is it, from clinician point of view or patient point of view, what is a difficult access, inability of clinician to remove the deposit completely, might be challenging anatomical features, could be deep pocket, furcation, which will often result in incomplete bacterial removal, and this can lead to, as we know, treatment failure. So when we take these difficulties into consideration, there are multiple treatment options that have been suggested to enhance conventional treatment, and one of them is use of dental lasers. So let me share with you a treatment protocol for periodontal disease. So my treatment protocol consists of full mouth assessment, including taking full mouth indices, radiographs and consent, and a thorough patient education, provide patient with laser safety eyewear, and depending on the severity of periodontal disease, I would usually treat 1 or 2 quadrant at a time, and a local anesthetic with a combination of piezo ultrasonic scaler and also site-specific curettes. I would, following a thorough instrumentation, I would irrigate the periodontal pocket with 3% hydrogen peroxide and photo-activate it using 940 nanometer diode laser. I would usually use, not usually, I would always use non-initiated, either 7 or 9 millimeter 400 micron tip, depending on a pocket depth, with 1.1 watt continuous wave settings for about 25 to 30 seconds. And additionally, following laser bacterial reduction within the pocket, I would use 0.5 watt, excuse me, per centimeter square for about 30 seconds per site on the outside of the pocket, starting from the apex to gingival margin to photobiomodulate the tissue. That's with either contour handpiece or surgical handpiece. And also at every appointment, the oral hygiene would be discussed with the patient, and I would always reinforce and review everything at the next appointment. So let me share with you my clinical case number 1 now. That's non-surgical periodontal treatment with adjunctive 940 nanometer diode laser. So that was a 58-year-old white male referred by a general dental practitioner for treatment of periodontitis. Medically, patient was fit and well, an ex-smoker with a family history of periodontal disease. So clinically, there was a generalized gingival inflammation. A suppuration was present in the upper and lower molars, as well as lower anteriors, along with pocketing varying between 4 to 9 millimeters and upper and lower posterior sextants. There was also an evidence of attrition on the upper and lower anteriors, and initial patient oral hygiene was really poor. with bleeding on probing 67%, and halitosis, and also generalized mature plaque biofilm, plaque score of about 80%. There was a tenacious supra and subgingival calculus deposit present in all quadrant and extrinsic staining. So I performed exactly the treatment that I already discussed, following my protocol, a root surface debridement under local anesthetic with a combination of ultrasonic and hand instrumentation, followed by adjunctive photoactivation of 3% hydrogen peroxide and photobiomodulation. I carried out the treatment over 4 visits, and the patient oral hygiene regime has been addressed and reinforced at every appointment. Now, on your left-hand side, you can see the initial indices, and on the right-hand side, post-operative indices are taken at 12 weeks. Oral hygiene has improved greatly. The bleeding score down to 2% from 67, and plaque score from 80 to 4%. So we can see a great resolution of pockets, especially upper right 6-7, upper left 6-7, similarly around the lower right and lower left, as well as the lower anteriors. And let me show you some photographs taken during the treatment. On your left-hand side, laser bacterial reduction with 940 nanometer diode laser. Top right is the photobiomodulation with surgical handpiece. And bottom right is the 14 months post-treatment. And some radiographs. So on a left-hand side, you see some initial radiographs showing vertical boning defects, vocation involvement, lower right 7, on the left-hand side. And on the right-hand side, that's 14 months post-treatment. A new scaffold of alveolar bone has formed around lower right 5, 6, 7, and as well as in vocation, and on the lower right, lower left 1 and 2. So that's 14 months post-treatment. Now let me show you my clinical case number 2. So that's non-surgical periodontal treatment with dual wavelength lasers. So that's your I+, water laser I+, and 940 diode laser. So that was an interesting patient because he has initially been to visit a periodontal specialist and has been told that in order to undertake any periodontal treatment, he would have to have 6 teeth taken out. The patient was not keen to lose 6 teeth to begin with, because then would have to still undertake surgical periodontal treatment. So he researched a lot about dental lasers. So he came to see me, and we performed exactly the same treatment that I've already discussed. That was adjunctive 940. That was first I+ used to remove any residual calculus, especially in vocations, vertical bony defects, and followed by a photoactivation of hydrogen peroxide. I carried out the treatment over 4 visits and reviewed the patient 12 weeks post. And these are the initial indices. On the left-hand side, patient oral hygiene was really poor. Patient was a smoker, actually, when he first came to see me. He's not a smoker anymore. He has quit. So that was really a good success story. But the bleeding score wasn't that high to begin with. Has reduced greatly to 3%, but the pockets, they've reduced a lot. During the course of treatment, patient has lost 2 teeth with us. Upper left 7 was perio endo, had some endo involvement and had to sadly be extracted. So we couldn't save those 2 teeth, but I believe better to lose 2 teeth over 6 teeth. So patient pocketing again has reduced greatly. I'll show you 6 months, the indices taken 6 months post-treatment. So patient hasn't got a pocket deeper than 3 millimeter. That was 6 months post finishing the treatment. So all the pockets are reduced from 10 millimeters down to 2-3.
Microphone.
Sorry?
No.
Let me carry.
Sorry.
on, and that's okay. And we'll have a discussion in a minute. So this is just an example. So before the treatment, June 2020, lower left 7, mesobuccal 9 millimeters. And we can see some furcation involvement. And 6 months down the line, December 2020, lower left 7, mesobuccal that reduced to 3 millimeters. Patient had no mobility 3 months post-treatment. So everything has improved greatly, and patient was really satisfied and happy with the treatment. My clinical case number 3, so similarly is a non-surgical periodontal treatment with dual wavelength lasers, so 940 and WaterLase I+. So this patient has been referred to me by a general dental practitioner. She is 34-year-old white female, no family history of periodontal disease, a non-smoker, and medically patient is fit and well. When you look at her mouth, you might think it doesn't actually look too bad, other than other underlying conditions, obviously, and malocclusion. But as we started to look deeper and take measurements and look at the RPG, it actually revealed quite advanced gum disease. So this is this lady's RPG. You can see great vertical bony infrabony defects on the posterior sextans. Also a little bone attachment around lower anteriors. And we have some impacted lower wisdom teeth. Her initial indices, so her oral hygiene wasn't actually that bad. These are her initial indices. What is really interesting about this patient is that she has been diagnosed with gum disease. It's going to be 3 years ago, sorry, by her dentist before, but because she was pregnant, she has been advised to postpone any periodontal treatment until the baby's born. Which we know we would not advise that normally, especially in this case, patient was medically fit and well. And obviously 3 years down the line or 2 years down the line, patient condition has worsened. Now we see that post-operative indices taken 12 weeks post-treatment. So some pocket reduction, great pocket reduction, especially up on upper and lower posterior sextans, as well as the lower anteriors, without actually increase or great increase in a recession. Patient tooth mobility has decreased to 0, and some pockets improved from down to 10 millimeter down to 2 and 3 millimeters. And let me show you some periapical radiographs now taken 12 weeks post-treatment. So initial radiographs on the top and 3 months post-treatment, lower right 6, pocket depth and of 9 millimeter, that has reduced down to 2 millimeters. And we can also see a nice infill of alveolar bone in the furcation, and a lower right 7, pocket depth of 8 millimeters, reduced down to 2 millimeters. Again, really good infills of the alveolar bone around the lower anteriors, anterior region, and lower left 6. That has reduced down to 2 millimeters from 6 millimeters. So patient has not lost a single tooth during this procedure. And again, really happy with the outcomes. My clinical case number 4, it was non-surgical periodontal therapy with adjunctive 940 nanometer diode laser. That was a 45-year-old white female. She was self-referred for treatment of periodontitis. Medically, patient was fit and well, an ex-smoker with a family history of periodontal disease. Clinically, there was a chronic gingival inflammation. There was a suppuration present from the upper and lower anterior sextans, along with pocketing varying between 4 to 9 millimeter. And again, there was an evidence of attrition on the upper and lower anteriors, as well as some grade 3 mobility of posterior molars. So patient initial oral hygiene, as you can see on photos on the left-hand side wasn't the best. There was a bleeding on probing of 89%, some halitosis, generalized mature plaque biofilm, some tenacious supra and subgingival calculus deposit that was present in all 4 quadrants. So I perform exactly the same treatment. So for my root surface debridement under local anesthetic with a combination of ultrasonic and hand instrumentation, so that site-specific curettes, and adjunctive photoactivation of hydrogen peroxide, 3% hydrogen peroxide, using 940 nanometer diode laser and additional photobiomodulation. Patient or hygiene again has been addressed and reinforced at every appointment. I've got some initial radiographs to show you. That was pre-COVID. I've treated this patient pre-COVID. Patient went to Italy, and she, as far as I'm concerned, I have seen the patient for 8-week review, but I have not seen the patient since. As far as I'm concerned, the patient is attending supportive periodontal therapy, but she's still in Italy looking after her elderly parents. So I'll be interested to see how she progresses with that. And what I found really interesting was that there was a dental implant, unrestored dental implant present in her mouth. And there was a sign of peri-implant mucositis already. So these are her initial indices, and indices taken 8 weeks post-treatment. Again, oral hygiene has improved. A bleeding score went down greatly from 89% down to 2%, plaque score down to 5%, and we see some really good improvement and pocket depth. And here are some photographs taken during the treatment. On the left-hand side, you've got laser bacterial reduction, 940 nanometer diode laser. Top right is the photo biomodulation with a contour handpiece, also known as a whitening handpiece. That could be only achieved backly. I would not recommend using contour handpiece for photo biomodulation palatally or lingually because of the curvature. I prefer using surgical handpiece without any tip. And let me play you a video during the treatment. So again, I performed a thorough root surface debridement under local anesthetic, irrigated the pockets with 3% hydrogen peroxide, and then used the 400 micron tip, 9mm in length for over 25-30 seconds per site. And I treated each site individually. And you can see, despite the really quite severe inflammation, the tip didn't initiate. Again, 1.1 watt continuous wave. Now, let me take you to dentine hypersensitivity. So the hydrodynamic theory proposed by Brandstrom explained that dentine hypersensitivity is a short, sharp pain arising from exposed dentine in response to stimuli. So that's thermal, evaporative, tactile, or chemical, which cannot be referred to any other form of dental pathology or defect. We know that there are multiple topical desensitizing agents that have been clinically tested and proven to have beneficial effect on dentine hypersensitivity. However, they all seem to provide a short-term relief. And hence dental diode laser has been introduced to increase the temperature on a tooth surface that cause either complete or partial closure of the tinotubules, and that brings an instant relief from dentine hypersensitivity. So this is my treatment protocol. Again, following full mouth assessment, we should always find out the potential cause of dentine hypersensitivity before we perform any treatment. and we need to address the cause accordingly. So what is dentine hypersensitivity on gingival recession caused by periodontal disease, then periodontal disease has to be treated first, or due to parafunction, so teeth grinding, malocclusion, or incorrect toothbrushing technique, that always has to be addressed first. Otherwise, you might find my treatment of dentine hypersensitivity with laser is not working, it's not effective. So test the tooth with either cold air, water, or I sometimes use my probe. If it's an individual tooth, it's best to use surgical handpiece with non-initiated 400 micron tip, or with the 0.8 average power on 50% duty cycle for about 45 to 90 seconds. And always stay away from the root surface at about 5 millimeter distance, and move the tip around and move as you move closer to the actual root surface. But it's important to note that you should not touch the tooth at any stage, and also you should continue moving the tip. Otherwise, you might cause a pulp overheating and cause some irreversible pulpitis. So if patient doesn't report any problem, and there is obviously continuing with your 45-second treatment, recheck the tooth. You can use, again, test the tooth with a cold air or water, sometimes scratch with a probe. If you have to, a little bit of discomfort is normal, but again, if patient reports there's too much heat, you can either move away the tip from the root surface or reduce the power setting. If patient doesn't report any problem, I would go on to do another round, increase the power to about 0.9 or 1 watt average on 50% duty cycle. Again, start again 5 millimeter away from the root surface and move the tip closer to the root as you move the tip and around circular motions. Again, retest the tooth, ask the patient if the patient has any symptoms. A patient would usually say it's one way or another. If patient still has symptoms, carry out a third application. No, I've never had any patient for more than 3 sessions, and sensitivity has been resolved completely. Patient is not using any desensitizing toothpaste and can eat and drink normally, including ice cream and cold water. If you find that there is, for example, a lot of recession in one quadrant or sextant, it might be beneficial to use contour handpiece. Settings will be a little bit different. So that's 1.4 watt continuous wave, 30 seconds per centimeter square. But again, I find using the tip probably a lot better, a lot more effective. So let me show you a video on a treatment of dentine hypersensitivity. So small circular motions, again, start about a few millimeters away from the root surface. Make sure you cover the extent of a gingival recession that was in this patient sort of case, and total length of the treatment should be around between 45 to 90 seconds. But again, keep moving your tip. Do not stop, because this is when patient will report a problem, or you might cause some overheating to the pulp. Right, so that video was about a minute and 10 seconds. So just to give you a rough idea. Next, I would like to talk a little bit about herpes simplex and after ulcers. We know that globally, this is a major problem, and according to WHO, there's around 3.7 billion people under the age of 50 that have herpes simplex virus 1 infection. And the estimated prevalence of the infection is the highest is in Africa, about 88%. Most infections are acquired during childhood and they're lifelong, and also infection, the most contagious when the symptoms are present. However, they can still be transmitted to others, even in the absence of symptoms. As we know, recurrent symptoms of oral herpes may be very uncomfortable. They can also lead to social stigma and some psychological distress. We know that the use of topical and systemic antivirals is effective to a degree. It reduces a viral shedding and infectivity. However, it does not cure the infection. These agents, they decrease the pain level, the lesion size and duration of the symptoms. However, especially with some systemic antivirals, there's a lot of side effects, such as one of them is nephrotoxicity. And with new research, we also know that there are some acyclovir resistant strain of herpes simplex virus that have emerged, and they're not really effective when it comes to using any systemic antivirals. So hence, again, diode lasers have been introduced in order to kill the surface virus that will inactivate the lesion. So in this process, the nerve endings will be cauterized, and that will allow the patient's symptoms to resolve. So laser therapy has anti-inflammatory, analgesic, and also healing stimulating properties. That will diode laser will increase the production of ATP in mitochondria, allowing the the lesion to heal a lot quicker, and also the level of serotonin and endorphins will increase. The production of prostaglandins and cytokines is reduced. That will eventually reduce the inflammation and also promote the healing processes. Now, with regards to aphatic lesions, we know that there are small shallow lesions that are developed on the oral soft tissues in the mouth and at the base of the gums. They're usually triggered by a lowered immune system, similarly to herpes, some emotional stress, vitamins or minerals deficiencies. But we also don't know how to treat them. Hence, again, diode lasers has been introduced to allow the treatment of successful treatment of herpetic and lesions and after ulcers. So let me share with you my treatment protocol. Again, always starts with a full mouth assessment, and I really would like to emphasize that we need to make sure that we're actually dealing with a herpetic lesion. We are dealing with after ulcers. If we're not sure, I would always refer patient back to see a dentist or to oral medicine department, perhaps to diagnose the patient if I'm not sure what is the lesion I'm going to treat. Again, patient education is very important. Gain the consent form from patient, provide the patient with laser safety eyewear. There's no need for local anesthetic. There's multiple clinicians that have asked me, do I numb the patient? No, there's no need for local anesthetic. I use non-initiated 400 micron tip on 50% duty cycle, so do allow the tissue relaxation. That's why we use 50% duty cycle on start with very safe setting, 0.8 watt average power. Again, similarly to dentine hypersensitivity therapy, 45 to 90 seconds. Continuous tip movement, 5 millimeters away from the lesion. I would start from the periphery of the lesion and move the tip closer as you move to the center of the lesion. Sometimes you might find a back and forth movement a little bit better. Allow the refractory period of about 20-30 seconds, and provide the patient with another application. If patient doesn't report anything, I would increase the power to about 1 or 1.1 average on pulse mode. And again, ask the patient how the patient feels during the application. If patient reports any warmth or any tingling sensation, this is when we actually know that we've treated it correctly. Patient should not report any stabbing or any great amount of heat. A little bit of warmth is okay, but again, we're there to always reassure the patient and stop if you must. So following diode laser therapy, there's a significant reduction in herpes healing time, also reduced recurrence rate without any side effects. In addition, we have increased skin blood circulation, lymphatic drainage. And this is what patients are reporting, that they actually feel that the herpetic lesion is shrinking during the treatment. So that will reduce the edema, and patients usually report less discomfort. Lesions do not grow in size, and they usually, on average, cross over within 1 day post treatment. So let me show you some of my cases of herpes simplex desensitization. Clinical case number 6, day 1 post-diode laser therapy, and day 4 post-diode laser therapy. This patient has actually attended a routine SPT appointment, so who was not sure whether he can have any treatment. And normally we know that we would send patient back home, because we know if a virus get infected in eye can be quite detrimental for patients. So I was able on that appointment not only carry out with my SPT treatment, but treat the herpetic lesion. And my clinical case number 7, day 1 prior laser therapy, and day 6. This particular patient has complained of having eruption of herpes every month, sometimes twice a month, for years, especially in the during summer month. Patient had to literally shield from the sun. We know sun can trigger eruption of herpetic lesions, but I've treated this patient 2 years ago. No, more than 3. It's going to be 3 years now, December. And patient has not a single eruption, has not had a single eruption ever since. Now, with regards to teeth whitening, let's just focus on teeth whitening, and I'll be talking about how diode laser can whiten teeth. So laser white 20 by BIOLASE comes with the base, which is a concentrated hydrogen peroxide, and the activator, which is a special dye. And when mixed together, the gel is activated by a specific BIOLASE diode wavelength. So in my treatment protocol, I begin by taking full knife assessment, constant initial photographs, take the shades, teeth shade, and provide patient myself as well as the assistant with safety glasses. Apply the Vaseline on lip. I've noticed that that makes a difference. They don't get that dry that much. Place the protective gauze over the lips and cheeks, and insert the cheek retractor. We have to apply the liquid dam, and again, that's to protect any exposed roots and gingivae, and mix whitening gel activator with the base, and following that, apply it on the teeth to form about 1 millimeter in thickness. Remember to place a disposable protective shield over the laser whitening handpiece, which is the white contour handpiece, to prevent any contact of whitening gel or saliva. And a diode laser 940 comes with a whitening preset of 7-watt continuous wave of about 30 seconds per quadrant. I actually prefer to focus on a sextant instead of quadrant, so that will be 30 seconds per sextant, so about a minute and a half on the maxilla, a minute and a half on the mandible. Repeat this cycle again, and following a second application, we can leave the gel on for about 5 minutes. Remember to always double check if patient's okay. If patient reports any problems, then we can do two things: either remove the handpiece, so keep the handpiece away a little bit from the teeth, or reduce the power. I wouldn't recommend doing both, because one might be just good enough. We have to remove the liquid dam and remove all the gauze. Safely advise the patient to rinse the mouth thoroughly, and inspect the soft tissues, review the shape, and take post-operative photographs, as well as provide patient with some post-operative instructions. Now, what I really like about the Laser White 20 kit, that it reduced the time of the treatment from an hour and a half, or sometimes 2 hours, to about half an hour. So it actually reduces your treatment quite a lot. So within that time, you can see another patient, you can make notes and things like that, but you can get equally good results. Laser White 20 also comes with a desensitizer, so that's about 3% potassium nitrate and 0.1% sodium fluoride. That can be applied immediately after the procedure, or you can provide the patient the desensitizer to take home if you're providing a home treatment as well. The manufacturer recommended time of use is between 15 minutes to an hour. I usually say to patients to keep it overnight, and if they have experienced any sensitivity, they can alternate. So one night they can have the desensitizer on their teeth, and one night they can have the whitening gel. And again, if the patient experiences any treatment during the procedure, we can either move the handpiece away from the patient's mouth, that will defocus the laser energy, or we can reduce the power slightly. So I'm going to show you some of my cases before and after. So again, on the left-hand side, top left-hand side, liquid dam application, then application of Laser White 20 gel on the teeth. Again, make sure all tooth surface is covered. And a quadrant treatment. I actually tried that, and I've noticed, because of the curvature of the handpiece, is better fitted if we focus on a sextant rather than the quadrant. That's before and after. And my next case, before and after. So my very last clinical case is a treatment of peri-implantitis with dual wavelength lasers. So that's your water laser IPLES and diode 940 nanometer laser. This patient has actually been told that she's going to lose the implant, but she was not keen. We know that peri-implantitis is on an increase, and we don't actually know of any effective treatment other than surgical treatment to treat peri-implantitis. Best, obviously, if peri-implantitis or peri-implant mucositis is treated or dealt with initially, so that it doesn't sort of get into this stage. This patient has, before seeing myself, her oral hygiene was excellent. She had some really big problems with the implant. When we taken the X-ray, September 2019, 6 threads were exposed. I carried out non-surgical periodontal treatment with dual wavelength laser. So my iClass, followed by the photoactivation of hydrogen peroxide. And a year and a month later, we see a great improvement in alveolar bone. So we have had only 3 threads exposed. and patient is undergoing supportive periodontal therapy. Implant is stable, there is no mobility, and again, patient is extremely happy with the outcome. So my last thing that I would like to discuss tonight will be some implication of laser use, not for dental hygienists and therapists, that is for all dental care professionals, and that includes our assistant. I believe this is very important, and there are some considerations that we should take into account prior even thinking about having a patient booked in. We should be attending a training, a really good training that will probably the best person to contact you about the training will be your local laser supplier. That will direct you towards where you can obtain a suitable training. And during the training, all the safety issues will be discussed, as well as the infection control and the way we're looking after and maintain the equipment. We must also inform our indemnity provider that we have successfully completed training. Sometimes they may ask about your treatment protocols and some laser settings, just in order for them to find out how are you going to carry out this procedure. In the UK, dental hygienists are allowed to use diode laser and erbium chromium YSGG laser within their scope of practice. And when it comes to erbium chromium YSGG laser, without removal any soft tissues, so I would use that purely for calculus removal. There is no, as far as I'm concerned, there's no increase in your indemnity fees if you inform your indemnity about the usage of laser, but they just want to be sure that you're using it safely and you are competent. Also, when using lasers, adequate laser safety eyewear is mandatory. That's to protect from eye damage, not only yourself, not only the patient, but also your assistant. So your laser safety glasses should have the optical density OD number printed or etched on your glasses. Should be 5, no lower than 5 when it comes to diode 940 nanometer diode laser. And the higher the number, the higher level of protection. Also, we know according to the Medicines and Healthcare Products Regulatory Agency, which is the executive agency of the Department of Health here in UK, all dental practices that use Class 3B and also Class 4 lasers should appoint laser safety officer. And laser safety officer will ensure that the laser is used safely and within the scope of practice. Laser safety officer has multiple different will undertake multiple different roles in the practice and ensure that the users are trained. Also will be responsible for training themselves, training and looking after the lasers, maintenance, also implementing any emergency action plans and incident report. So that is a very important person in your practice. Now, with regards to a laser plum, so this is a smoke that is produced during laser initiation. We can see that mainly with diode lasers, when there is this smoke coming out from the pocket, obviously when the fiber is initiated, that's quite hazardous for both the patient, clinician, and your assistant. Hence, we should be always using the high aspiration. Also, we need to remember to minimize any reflective surfaces, so don't shine a laser onto your mirror. And diode lasers can also produce the thermal radiation, and hence they also increase the risk of fire. We need to have a correct signage outside and inside of the surgery, and I would emphasize on creating a checklist before and after you've used laser. Correct PPE, as I mentioned, and we need to follow the correct decontamination procedure that will be in line with manufacturer instructions. We also need to ensure that there's enough time during the treatment so that we don't rush, because when we rush, we know there's more chances of error to happen, or we might actually have insufficient time to perform the procedure and then believe that the laser is not effective. The cost of the equipment and the maintenance that should be taken into consideration. I'm not aware of the cost of the diode laser, so 940 nanometer, and your water laser I+ in Denmark and South Africa. This could be discussed with your local laser supplier. But what I do know is it's a great investment, and you can get your return of investment, for example, a diode laser within, I want to say, quite confidently in a month. So it's definitely worth investing. And we need to, the last thing I want to mention is for all of us to involve the whole team in training. So even if there's just a hygienist or just one dentist using a laser in a practice, all professionals should be informed about the laser, your reception staff, your nursing staff, because they will be asked by a patient. And it's great if the team is trained and able to inform the patient about such procedures taking place in the practice. And again, even if they're not using it, I found it really beneficial. So I believe that brings me to the end of my presentation. You actually might be surprised to hear that when I first came across laser therapy, I was actually quite skeptical about the effectiveness. However, the more I applied the laser, the more I discovered that really amazing potential. And especially when I saw the results and also patient feedback. So by providing this alternative and holistic treatment, I'm able to actually shift patient perception about our whole profession, and also have really amazing relation with my patients. So I definitely have a lot more confidence in the outcomes of the treatment, are a lot more predictable. So I definitely have a lot more job satisfaction and fulfillment, and I'm able to attract the new patient and retain existing patient to within my practice. Having said that, it doesn't mean I don't refer patient to see specialists. I still refer patient, but the chances of patient having a surgical treatment are far greater with a specialist than obviously with myself. And why would patient even want to have surgical procedure if they know that they can get a better outcome using non-invasive laser? So I would like to finish by inviting you all to inspire all of your dental teams, whether it's endodontist, oral surgeon, whether it's a nurse, cosmetic, general dentist, whether it's a hygienist, or whether it's a therapist, to get involved in this amazing technology, because the outcomes are just fantastic. And especially now, within COVID times, there is so much more that we can provide to a patient and have really an amazing treatment outcomes. So thank you so much for your time. If you want to get in touch, this is my email address, my LinkedIn address, and Instagram. If you have any questions, please do get in touch. And I would like to thank you all for your time. And thank you, SciVision, South Africa, and Nordic for inviting me to run this webinar, and to all my fellow colleagues. And I would like to welcome any questions you might have now. Thank you.
Okay. Thank you, Beata. Very good. You were going nonstop for an hour. Amazing.
Really?
I want to compliment you on your presentation, and especially your clinical outcomes. I think it's really inspiring. I think it reminds me of that film, Top Gun, where the one pilot said to the other, "You can be my wingman anytime," but Tom Cruise said back to him, "No, you can be mine." So I think for any dentist to have a hygienist like you in their practice And for patients to have a hygienist to go to with your vision and using laser technology the way you do would just be such a blessing to that particular patient and practice. So I just want to check. I'll just ask Alex to comment anything. I mean, you went through many cases. I think he was really wanting to say something about some of your regenerative bone regeneration cases in the beginning, because Alex does a lot of surgery as well and implants and so on. And his wife does a lot of root canal, so they complement each other in the practice. I think she's trying to save the teeth and he's trying to put an implant in, but I'll let Alex add more to that. Thank you, Alex.
Yeah, well, especially, you can hear me?
Yeah.
Yes.
Okay, very good. So the peri-implantitis area is very important, I think. Of course, the other things are very, very exciting, but the thing is that we really don't want to, how can you say, damage the surface of the implant. So that's why if you want to remove the bacteria, I think the laser is probably the best to use, because of course it's the 2780 nanometers, because there's no absorption in the titanium, because the absorption is in the water content. So I use it really a lot, more and more non-surgically, and also surgically. Yeah, so it's in a growing area, very. So I'm so happy to see very good results of yours too. Yeah.
Yeah, thank you, Alex, and hopefully one of these days you'll share with us some of your results that you guys are achieving there in Denmark. That's great. Avi Thomas, Avi, have you got a comment or a question?
Yes, thank you very Beata on a very good presentation. It was very good. I just enjoyed what you can do, and especially for you as an oral hygienist, I can see that you're really interested in the lasers and you've got beautiful results. It was all well done, and I've got no questions. I am just applauding you and say well done.
Thank you.
Yeah, Beata, I can certainly see that. I mean, all of your settings you went through as well, it's totally in line with what we've been teaching. And I can definitely see you've been in very good company with people like obviously Mark Cronshaw and Rona Alfalaki, and a lot of us in South Africa, and Alex and them have been trained, by the late Professor Norbert Goodnecht, and the physicist Dr. Renee Franzen. So, everything you've been talking about too is very much in line with the training we've been giving too. We've also got, actually, funny enough, this coming Saturday, we've got a WCLI meeting in Cape Town, a full day session. So there's already quite a lot of bookings for that. And we definitely see the increased demand for dentists looking out, for lasers, and especially wanting to get some level of certification and training. So I'm glad you brought up the topic of training, because that is becoming more and more important, because, all lasers aren't the same. The wavelengths are different. And the way you use the laser is very important. I mean, there are some questions I've seen that have come up. We'll try to get some of them. And one of them, for example, was, can you use the laser to treat Bell's palsy? And yes, we've been treating some of our dentists that use it, medical doctors and so on, and physiotherapists have been treating patients quite successfully with Bell's palsy, as well as trigeminal neuralgia, alveolar nerve damage, even shingles. Things like that. We've had some very, very successful results with using the 940 diode laser for those kind of treatments. Lindy, I'm not too sure if there's any one or two questions you want to mention as well, because I know it is 9:10 in South Africa anyway. So those of you who would like to leave and go to sleep or cook some food or say goodnight to your kids, you're welcome to do that. As far as I know, this will be recorded. So I think in about 48 hours, there will be a recording available. So you could watch it again. And just want to check, Lindy, any questions you'd like to ask now? If you might have. Avi, I see you've come on. Anything you wanted to say? Not your answer.
No, as I've just said, I think this is just such a great presentation. And thanks, Peter, for you and BIOLASE for hosting this type of meetings, because it's not possible for us to travel all over the world today and to attend certain meetings and congresses. And this is just absolutely beautiful. I am very much astonished by an oral hygienist doing this type of work and seeing this type of results. Because in South Africa, I haven't seen this before. So yes, and then once again, just shows that Mark Cronshaw and Rana, the people from the WCLI and Justin Kolnick, the people that are really interested in these laser developments, the treating of patients, the saving of a tooth, prevent an extraction. This is just amazing. So once again from me, thanks again, Peter, BIOLASE South Africa, or BIOLASE,
Okay.
and SciVision South Africa. This is really good. And thank you for asking me to be part of this company tonight. I really appreciate that.
Good. Alex, any final comments from Denmark?
I totally agree. This representation was very nice, very good cases, and well, there's something to aim for us. Very good.
Yeah, we trust that Beata is going to really inspire many more hygienists in Denmark and Norway and Sweden, and
That's
obviously
my
the
aim.
UK.
That's my aim.
You're already doing it in the UK, and in South Africa, we'd certainly like to see more hygienists step up to the mark. Of course, there's always the question about, can a hygienist use a laser? And I mean, it certainly seems to be a gray area. Nobody really wants to put their sort of name on the dotted line. But as far as we understand, is that as long as the hygienist is staying within her scope of practice, so she's removing calculus, or you can use a scaler, a hand scaler, a piezosonic scaler, or you can use a laser, as long as you're not going beyond that scope. I know in Denmark, Alex, your hygienists can do even more advanced procedures, as far as I heard, even a frenectomy or gingivectomy, as long as they're under the supervision of the dentist and within their duties in the practice. Am I correct?
Yeah, you can say, well, I take full responsibility of what they are doing. So it's a trust thing, and of course minor surgery things, but of course subgingival scaling, of course, and yes.
I would like to just add, if I can, unless we perform really effective root surface debridement, there's multiple great treatment options that we can apply, but I have not yet seen something that amazing as laser to give us such a wonderful results within such a short period of time. But again, I would like to emphasize that really good instrumentation has to take place first, because even in mild cases or mild cases of periodontitis, we won't get good results. And this is something that I came across multiple times. I do one-to-one training as well for hygienists, and they often ask me, but it actually nothing happened. And then when we go to revisit the pocket, there is a deposit left behind. So again, we need to follow our conventional treatment first and get on top of that, and then apply obviously laser. I hope you agree with me.
Yeah, we do agree. I think that the big point is to always confirm that laser is adjunctive treatment.
Yeah.
It's not replacing your scaler and etc. You still do that, and you add laser to those things. And we certainly see, especially with perio and root canal, the ability of a diode laser to destroy bacteria is just immense. And obviously the biostimulation effect is also really good. And I also saw your treatment protocols in terms of the joules per square centimeter, the dose that you're giving, which obviously is also very, very important, because we do find people saying, well, I've tried it and it didn't work. And then we ask them, well, what settings did you use? So it's important to use the correct setting, and also to understand your anatomy. So especially if you treating something that is obviously alveolar nerve, for example, we find often people read the studies and they see you should treat it, for example, 5 joules per square centimeter, but that is on the site of injury, not on the surface of the tissue, because it's still got to go through the soft tissue and the bone. So understanding how the laser works, how your specific laser works, and as well as understanding the anatomy is very important. So one question was also, I saw posted about training for oral hygienists. And yes, from SciVision's point of view, and our group of dentists, whether it's from the WCLI or our other dentists that are master trainers as well, and have attended numerous trainings, we offer training in South Africa, in Denmark and Sweden, and other countries as well, for hygienists, of course, and therapists, if there are therapists in the country, as in South Africa, and of course, dentists and specialists. We've also even had a maxillofacial surgeon on one of our mastership courses. So from periodontists to prosthodontists to, we're training up vets as well, physiotherapists. So as a company and with BIOLASE's backing, we understand that very much the need for training and ongoing training. It's not just once-off training and off you go. We find that the training works in layers. So when you understand this, then you understand the next level better. And so your knowledge grows. So we're very blessed in South Africa, and Denmark is coming on too with Alex and Anne and doctors like that, the group of really not only good users, but well-trained operators is now starting to grow as the knowledge expands. And I think it's really exciting to see that, from your point of view, that you're nudging the hygienists to say, come on, step up and use this technology for the benefit of the patients. Okay.
Most certainly, Peter. Yes, and Peter, just to connect with what you were saying, is that really we need people to come to the courses, to invest their money, and to learn and to know what the late Professor Goodknecht just told us: never be a button pusher. Don't just push the buttons. Come and understand. And Beata, I can see that you do understand a lot more than a lot of dentists, I believe, know and would not accept, because they're just too proud. And once again, thank you for your insights tonight. I really enjoyed it, and I have an opening in my practice if you should consider reallocating.
That's very kind of you. I think for the time being, I should continue working and expanding, demand of lasers in the UK.
No.
But who knows?
Well, I will release you, Beata. Thank you very much for your time this evening. I know you're an hour behind us. So in London, I know you can still go out and have some fun. So
have a braai. Have a braai.
With my 2-year-old boy.
But thank you very much, and we look forward to speaking to you again. I'll let Lindy speak here.
I would just like to show everybody, because no matter where you are, you might want to join the mastership course with the Aachen University, a very well-known course. And I know in South Africa we've had some Americans join us, we've had some Danish join us, and it's really a wonderful group. Really, really, it's just amazing to see all the dentists really having light bulb moments in this course. So the next one in South Africa, if you'd like to come on a safari, you're always welcome to join us on the 30th of October. That's quite soon, for Module 1, starting with the Erbium Chromium YSGG module and the Laser Safety Officer module. And then in Denmark, in Vale, Alex, correct me.
Yeah, Vejle.
It looks very beautiful, by the way. We are starting there on the 12th of March, and it will end towards the end of in 2022. So please join us for that. And this is the WCLI program that's available. Of course, if you go to the WCLI website, wcli.org, there's many opportunities for training there, from certified training courses, one-day associate fellowship courses. We've got one in Cape Town this weekend, and then again in Johannesburg on the 29th of January 2022. The forums, the symposiums where you can actually do your mastership with the WCLI or your fellowship, just like Beata did. So look out for these on the WCLI website. There's just so much. So do join us. Have all the questions been answered?
I'll just have another look quickly. I think we've pretty much answered
Somebody asked, did you say one may skip acid etching and place the filling just after using the laser on the cavity?
So I would use still acid etch, depending on extent of cavity. For anterior teeth, there's no need to acid etch. So that's one of the greater benefits of using erbium chromium YSGG and restorative treatment, is that it actually removes the smear layer and debris, so there's no need for acid etching. Would you agree?
Yes, well, that's what the doctors are getting taught in the in the mastership course as well, because we know that the erbium laser, we're talking specifically about the erbium chromium, the water laser, that is excellent for removing the smear layer and the biofilm, and that's also why it is so effective in the root canal, because it's, you know, and the question always comes up too, well, should you still etch or shouldn't you? Well, if you want to, if it makes you feel better, you can still etch. And the same as in the root canal, there's always this discussion of, you know, do we still need to use chemicals? So we've got some endodontists that are really well trained at a mastership and MSc level. They may still use sodium hypochlorite, a low one. I think Dr. Kolnick talks about, you know, using a very low percentage and doing his apical activation of it, or a very low percentage. Other endodontists as well, like Miguel Martins, as far as I know, he may still use sodium hypochlorite during his instrumentation process. But if it's especially a retreatment and the apex is quite large, he then won't activate the sodium hypochlorite for standing too much of a high chance of it, you know, going through the apex. So in many cases, they'll just use water with the water laser, and then the diode laser afterwards, because it can disinfect much deeper into the lateral canals, getting, you know, according to the studies, up to 1,000 micron, being very effective in destroying bacteria. So the water laser, because it's highly absorbed by water, we know that it's being absorbed roughly about 300 microns. So the disinfection in the root canal is not as effective as with a diode, but we first need to remove the smear layer and the biofilm. So sorry, Beata, I know you don't do root canal, but it's one of our passions here too.
Which I'm really glad.
Yeah. Peter, may I just come in here to say that there are proven studies that we've seen in Aachen, that when you do use the laser and there's a specific setting that you can use, you do not need to etch the tooth anymore, because the laser etching under the electron microscope is sufficient. So you can just straight bond, etc. So in my practice, I use very, very little etching whenever. Yeah, that's my comment.
Also, etching can increase the sensitivity post restoration. So you would use that with caution. Am I right?
Yes. You're quite right. And what we've seen is, in a couple of studies, is that that if you do not properly rinse, or you have an undercut in a cavity preparation and etch stays behind on the tooth, because you really have to wash it very clear and clean, that definitely causes post-operative pain, etc. So yes, etching is good, but with a laser, it's final. As I say, I use very little etching in my practice today.
Good. Thank you very much. We will say good night. Goeienaand in Afrikaans. And I'll catch up with you soon about some dates to maybe come visit us in South Africa, Beata, and as well as Denmark.
Yeah.
I know.
Thank you.
And remember my offer, Beata. So remember, and I'll see you all in Cape Town this weekend.
Yes, good. Thank you very much. Thank you, Alex. Thank you,
Yeah,
Avi.
thank you. Thank you.
Thank you. Wish you all good night.
Beatrice. Thank you,
Yeah,
Beata.
thank you. Thank you.
Good night.
Bye-bye.
Bye-bye.
Bye-bye.